Hey guys, welcome to our Gonstead Advanced Club. I'm Marcos Pervalaris.
And I'm Macy, and today we're going to be going over lumbar pulls. And the first number one rule that we want to remember when we are doing lumbar pulls is it's actually a finger push, not an actual pull. So this is going to allow us to correct the misalignment in all three planes. So next, we want to go over when to use the pull move. So we're going to use the pull move when there's a considerable amount of body rotation, if there's a lack of lumbar lordosis, or if the patient is super acute because it's lighter, quicker, and we want to be extra careful that we're not rotating them too much to injure the disc.
All right, so right now we're going to go over our basic context point on the spinal model here. We're not going to go over too much of the misalignments. Last video that was made actually did an amazing job of representing the misalignments and how the bone is misaligned. So if you need to get re-upped on that, last video would be a great video for you guys to check out. So what I'm going to quickly go over are the three different main contacts that we have for a lumbar pull move. On top of the different contacts, there are different ways to go about it. We are taught a few different ways. You can kind of do like a raptor claw in a sense, where you either engulf the whole spinous or you just engulf the entire mammillary, but you can either do this type of grip or you can do the grip that is also referenced in the chapters as well. If you're going to do a spinous listing, again, as you can see in our reference sheet, we say that the side of spinous rotation is down. So right now for this specimen, this would be a PR or a PRS. So if I was going to do a PRS at L2, I would contact my second and third fingers on the lateral inferior side of the spinous, and then have my thumb as my pivot point right here. Okay? And again, just like Macy said in the beginning, it's very important to remember that this is a finger push and not a finger pull. So to correct this, we are going to lift it up and push down to take care of that PRS, okay? If we were doing a mammillary listing, just a normal PRI-M in this case, we would have our third and fourth fingers, according to the chapters, on the side of the spinous, our second finger on the mammillary, and then our thumb right here on the skin for the pivot point. Again, this takes care of the rotation and the wedging on this side. As you can see, we are on both going P to A, I to S, and whatever way the direction tells us to. If we're doing the raptor claw way for a PRS, I'm gripping the entire spinous, keeping my wrist straight. I'm not bending too much, or I'm here. I'm keeping it nice and straight. And I'm going to lift and set down. Again, a finger push, not any pull at all, because that's only going to take care of the rotation if I do this. I'm not going to get the P to A, I to S, and taking care of that wedge. Okay. So the last one that we're going to go over is the special L5 contact that's mentioned in the chapters that we overlook a lot. And this is because of how the L5 vertebra, as you can see on our model, is very different compared to 4, 3, 2, and 1. You can see we have much stronger transverse processes as opposed to these blade-like, very not strong TPs here. So when you're doing L5, you actually have the chance to utilize that transverse process. So what we do is we put our third finger on that lamina right there, and then our second finger on that transverse process, and then we have our thumb again as our pivot point, okay? And this would be for a PR-M, a PRI-M, or even a PRS-M for the special listings, okay? So what we're going to be doing is go in the direction of the thrust, but again, we are lifting and setting down, okay? It's not at all going to be pulling or flicking. As you could see while I was doing that, I'm going down that disc plane line as well, right? We're not just jamming in or pulling across. We're lifting it on top of the disc and setting it down. All right, so now what we're gonna do is show you those exact setups on the patient. So right now, as you can see, Macy's left side is up and she is in her perfect patient placement that we want. It's important to make sure that the patient is in the right placement, because if the patient is too far rolled, by the time we try and get going, we're rolling her too much. And you can see the torque in her back and just how uncomfortable that looks. So we want her to be pretty neutral when we're ready to do this adjustment, okay? So right now we have her left side up, so we would be doing either a PR, a PRS, or a PRI. Okay, so right now I'm going to show you with the Raptor Claw first, and then we'll go into the other ones after. So again, we're making sure she's in her perfect position right there. I'm going to roll her a little bit to get my contact, but I will be rolling her back. Okay, so I'm finding my contact. If I'm on L5 right now doing just a PR, I'm going to tissue pull to that right side of the spinous, and if it's the Raptor Claw, I'm getting completely underneath that spinous and wrapping in here. Okay, going to distract up, roll her back a little bit, then I'm going to slide my foot up without losing any of that slack. My hand will be going straight in, lifting and straight in. Since my contact point is on the certain side of the spine, so it'll take care of the rotation, and this will take care of the posteriority, okay? My stabilization, I am going down and into the patient. Going down and in. As you can see, she doesn't twist at all when we do the stabilization, okay? That was for a PR. Let me show you the PR with the other grip. It depends on your patient that you'll have. Certain people will feel more comfortable with feeling the grip. Some people just have a more comfortable set with certain ones, and that's okay. So what we're gonna do here is have our contact point like this. And as you can see, I'm still on the inferior right side of that spinous, and this is now my pivot point. It's the same idea. I'm gonna make sure I'm stabilizing her well. And we're going straight in that arc down that disc plane line, okay? Now lastly, we'll go over a mammillary listing for L4 for right now. So I'm gonna find L4, and remember where that mammillary is when we're doing it, okay? So knowing your anatomy is very important. Your mammillary is going to be right here. It's not right there, it's right here. So knowing where you're trying to find that contact point is very important. So if I'm going on to L4, I'm going to tissue pull I to S over lateral to that mammillary. If I'm doing the Raptor Claw, I'm staying like this. If I'm doing the way they have in the chapters, I'm doing 2 on the spinous, 1 on the mammillary, and then my pivot point right there. Again, my wrist is straight, it's not bent, it's not flat, it's strong. Going to slide up. As you can see, we're going down into the table and the patient doesn't rotate at all. Okay, the last one we're gonna go over again is that special L5 listing where we can use that transverse process. So we're gonna find that L5. We're going to put our third finger right off to the side of the spinous on the lamina, and our second finger right onto that transverse process. This thumb acts as a pivot point. And again, Macy is flexible, so I have to be careful that I'm not just going away and then hopping on. You can see how much she rolled already. So as you can see, my right leg, as I'm sliding in, I'm never losing contact with her, and I'm making sure that she's staying stable. So this would be for a PRI, a PR-M, or a PRS-M, okay, for L5. Down and into the table, okay? All right, so now I'm gonna show you guys the back side of my stabilization. I want you to notice how my body is directing into the patient and not coming back, not coming down, but going down and into my contact point. You can see my hips are gonna stay strong and sturdy. I'm going straight down and in instead of rotating and twisting down, okay? So I want you guys to check out the stabilization point for this part of it. So we're not worrying too much about our contact. And again, her right side's up now, so we're doing either a PL, PLS, PLI, so those type of listings right now. So when I'm on my contact here, and I'm, again, distracting up, not back, up, very different. And I'm going to, with my left leg now, on my stabilization, I'm never losing contact with the patient. I'm always staying strong. Because if I just do this, she's all twisted and she's tense now. And I lost my slack. So I'm keeping her here. I'm bringing my leg up, keeping that contact and staying strong. Okay? Now, when I'm ready to go, getting my epidural notch over my contact point, I'm going down and into the table. And that's the stabilization that we're shooting for, because we do not want to do any of the things that Macy's gonna go over right now. All right, so now we're gonna go over some common mistakes that a lot of people make. And we're gonna start with the number one rule that Macy mentioned right when we start, that this is a finger push, not a pull move. We label it a pull move to differentiate between the actual push and this move, but it's the same idea going through different contact points of your finger. Okay, so I want us to watch what the difference looks like between a pull and a finger push move. So first, I want Macy to do a finger push. As you can see, she's pushing it down through that displane line just like that. Too many times we see a finger pull. As you can see what it does to the pelvis, it rotates the pelvis, rotates the spine if it's stable, and a lot of just really other factors happen with which is what we don't want to accomplish. We want to accomplish getting that subluxation fixed at that segment, and just that, not influencing too many other things. And when we're sloppy and we twist, that's what happens. So now the next mistake we're going to go over is the stabilization leg, and where the misconception of the kick that we hear and are taught sometimes in school. This is not a soccer ball kick or a starting a motorcycle kick. As you can see, that will only rotate the spine as well. So if you come on over here, you can see our lovely teddy bear. If we had an actual patient, just imagine how much that twists the spine when you pull and you use that leg to kick it down, okay? What we truly want is controlled and down and into the table, okay? This makes a huge difference for patients and people that are not well, because if you're twisting too much, that is the easiest way to hurt a disc, okay? And the patient's coming in normally with an injured disc as it is. So you're really putting them in a compromised spot. So that kick will only make matters worse. And that's why when we're able to do things this way, we're able to adjust a lot of patients that normally wouldn't be able to be adjusted in other situations, okay? So this is very important to make sure our kick and stabilization is exactly this, down into the table, and not a kick. You can see how much that rolls, okay? So the next part we're gonna go over is how we want the patient's shoulders positioned. Like I mentioned when we were doing it slightly during the setup, we want the patient's shoulder to be distracted up as opposed to back like this. Again, we're trying to minimize any bit of rotation and twist in the spine as possible. The more you minimize it, the better outcome you'll have for your patient. It's really just that simple, and being sloppy is never an excuse for rotating a patient, okay? So that's why we wanna have it the way that Macy just did that, and that's very important, okay? The next thing that's important is where the patient's knee is. So when, again, someone is in pain and they're acute and you're using this move, the last thing you wanna do is rotate them and hurt that disc or hurt their leg. So when you have to be very conscious of where that front knee is, because if the patient's too far back and you roll them too much where that knee gets compressed on that table, you try and kick down into that, I can guarantee that this patient will not like you. And that works for whether you're doing it the way we're trying to teach, down in the table, or a kick. The kick is even worse because you'll just be very strong and hit that knee into the table right there. Okay, and the last mistake that we're going to go over here is how far to roll the patient. So we talked about this a little bit when we had when we were doing the setups, but again, we want the patient to be neutral. Okay, we do not want to do too much rotation, too much twist, and if you roll them too much, again, you're probably not even going to accomplish the line of direction that you want. Certain patients, yes, you're going to have to roll more than others, but for the most part, you want their pelvis helping you stabilize yourself because you have less stabilization with the pull move. So we want the patient straight and upright, just like this, and when Macy goes to do a thrust, it's compressed, it's down, and there's no rotation. If you start rolling that patient, gravity comes in, then all of a sudden you're kind of forced to either twist or let the patient fall onto the floor. Okay? So these are some of the common mistakes that we see, and we want to make sure that you guys are aware of them so you're aware that you don't make them.
Thanks for watching today, guys. We really hope that you're enjoying the informative videos.
Yeah, and if you guys are having any questions about anything that we've done so far, these are just topics that we've came up with to help with what our club was focused on. So the beautiful part about this is if you need your catch up on listings or other things at all, please look at our other videos that we have and subscribe to our channel because we're going to keep posting videos as long as we can. It's very important to also look on our Facebook or Instagram because we have reference sheets that we have also made as well that can help you guys follow along with what we're teaching and have as a resource to always keep in the back of your mind. Okay? We hope that this is one of the last couple weeks that we're going to be doing this and we're in person again soon and we can get the hands-on work. But for the people that we're reaching internationally and over the country, we appreciate all of the feedback and all the comments and the support for what we're doing. And when we get back in class, we're actually going to keep doing this for those exact people because it's about helping the Gonstead community grow, not just our school. So we thank everyone that's been watching, supporting us, and we hope to see you guys again next week. Thank you guys.
Thanks, guys.